Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. On August the 7th, 2024, the Director General of the World Health Organization, Dr. Tedros Ghebreyesus, announced an emergency meeting with an expert group to determine if the current outbreak of Mpox constitutes a public health emergency of international concern. According to the Africa Centers for Disease Control and Prevention, it started in the DRC and has been detected in 10 African countries this year, with DR Congo accounting for over 96% of all cases and fatalities. Experts say this variant is highly infectious, allowing it to spread rapidly among individuals and is causing serious concern. Nearly 70% of the cases in Congo are among children aged 15 and younger, and these children make up 85% of the deaths. Mpox is a viral illness caused by the Mpox virus. Common symptoms include skin rash or mucosal lesions, which can last 2 to 4 weeks, fever, headache, muscle aches, back pain, low energy, and swollen lymph nodes. My guest is a virologist and executive director, Global Health and Infectious Diseases Control Institute, Nasarawa State University, KEFI, Dr. Akiala Ishaku. You're welcome to the show, sir.
Thank you, Mary, for having me. Good afternoon, Nigerians. Good afternoon, viewers.
I'm curious about this new variant of Mpox, which they say is more virulent. Spreads easily and is more infectious. What can you tell us about it, and is it in this country yet?
So thank you for having me and thank you for the platform. You will understand that during COVID, we have different variants of the COVID virus. Once a viral particle have an interface with an environment or with a different host, it changes its genetic makeup. That genetic makeup gives rise to a new virus, we call it virions, that have distinct genetic characteristics that can either make the virus more infectious or less infectious. And it is also often referred to as variant. So in COVID, we saw the Omicron variant, we saw the Delta variant, and virtually all the variants that are associated with COVID became much more pronounced during COVID. Now, in the same while, we have variants in monkeypox. Monkeypox was dated around 1950. It was discovered in a research monkey. That's where the name comes from. In Germany. And, since from then, it was also traced by genealogy, what we refer to as phylogenetic tree analysis, to two distinct, to a continent called Africa. Now, the variants that are in circulation in Africa are two. One from the Central Africa, for sure, that's where you began your introduction to DRC. And then we have another second variant down in West African sub-Sahara coast. Now, one of the variants that is more infectious is the one that is in circulation in Central African Republic, the DRC and other countries within the Central Africa, because of increased infectivity rate, increase in severity of the disease, increase in hospitality rate, increase in mortality rate, increase also in morbidity rate is associated with that variant. That variant is referred to as clade 1. The one that is more prominent in West African region that has less infectivity rate and less hospitalization and severity rate is found within the West African coast, which Nigeria is inclusive. Now, there has not been any authority or documented evidence that we have a new variant in circulation in Nigeria, either by NCDC or by associate agencies that are into genetic surveillance or genetic epidemiology. But Mary, I want to say that your question posed a national concern. How often do we do genetic epidemiology? How often do we do genetic surveillance? How often, with the porous nature of our border and endemicity of infectious diseases, how often do we do genetic or genomic surveillance? So if we are into genomic surveillance, because I was also reading from literature in the UK yesterday, the UK health agencies came up with a publication that they have gotten over 3 circulating genotypes of this monkey virus, 3 circulating variants of this monkey virus within the UK, because they have a robust testing platforms, robust genomic surveillance system that is in place. Since the aftermath of COVID, post-COVID, we never took advantage of sustainability plan to actually control, to continue in the light of doing genomic surveillance. If we would have done genomic surveillance, we would have seen whether we have circulating variants.
Can I quickly butt in? What is the mode of transmission of Mpox? I ask because there was a time it had never really gone beyond Africa or to the Western world, but now they are talking so much about it. How does it spread?
So originally, monkeypox is a zoonotic disease. It's a disease of animal origin that is transmitted to humans. But human-to-human transmission is possible, and that's what we refer to as direct contact. So if you have a direct contact with animal or animal fluids or animal fecal materials, or you have direct contact with animals, you tend to, and the animals, because they are reservoirs in animals, they can be transmitted to humans. You know, Mary, that the nature of our husbandry in Africa, we keep animals even within the habitation of human populations, and so the chances of transmission of zoonotic diseases are very high. Now, there is also the human-to-human transmission. One of the signs and symptoms of monkeypox is that you will discover that there are issues of rashes. Now, these rashes, once another human get encounter with another human that have these pronounced rashes, the chances of transmission are very high. And so we see that more commonly among children. So in places where there are overcrowding, the chances of transmission of monkeypox are very high. So back to your question, it is a zoonotic disease. It can be transmitted from animal to humans. It can also be transmitted from humans to humans through direct contact.
Okay, in 2022, WHO called Mpox, a global emergency. That was the first time we're hearing of Mpox as a global emergency. It had spread to about 70 countries. But at that same time, we had Mpox in Africa, and we were not considering it as much, especially we know about Nigeria. We were not so bothered about it. What criteria are used for declaring an emergency of international concern?
Yeah, so there are 3 basic criteria that you can describe a public health emergency. 1, it depends on the origin of the infectious agent, which it can be viruses, it can be bacteria. You remember when there was a variant in South Africa, it was discovered in South Africa during COVID. It was declared an international public health emergency. So the origin of the virus is a major concern. So it's a criteria. 2, you have to look at the transmissibility and the infectious trend probability threshold of the variant or of the infectious agent. In terms of monkeypox, you will discover that because of globalization, because of international travels, and because most of these infectious agents that emanated from Africa, the Western world don't actually pay much more attention to it, because even most of them produce most of their diagnostic tools and treatment regimen for us in Africa. And so through globalization and international travels, we can export this infectious agent back to the West. And so this is also a criteria for you to pin down that there is a public health emergency. Then 3, it is the pandemicity. The pandemicity looks at the spread globally. How many countries are infected globally? What is the threshold of the transmission globally? And what is the mortality rate? So we have what is called the case fatality rate. How many people have died of the disease per time, per place, per person, and per country? I'm quite happy when you are doing your introduction about monkeypox, you established that it cut across 70 countries of the world. So if it cut across 70 countries of the world, it shows that it is actually tilting towards a pandemic state, and so it can also be termed as a disease of public health concern.
So in 2022, the Western world actually claimed that they used vaccines to tackle their outbreak. But we didn't use vaccines in Africa. Now, would those same vaccines work for this new strain that we are seeing?
Now, the good news about monkeypox is that, vaccines for smallpox conferred immunity for monkeypox. And, because of our genetic makeup in Africa, God has so much blessed us and endowed us with an immunity that will establish herd immunity. And that's why during COVID, people thought maybe we'll be dying on the street. But we were healthy and hearty. In fact, people that even had COVID went to football field to play football and returned back home because a herd immunity was established. Now, during the eradication of smallpox, it was also established that there is an overlap of immunity that is covered if you take a smallpox vaccine that covers monkeypox. Now, so the issue is that there is no tentative vaccines candidates for monkeypox. A lot of the vaccine candidates that I've read and I've watched over time, they are at different stages of clinical trials. Now, but vaccine designs are done in such a way that it also precedes the future. Anytime you are developing a biotechnology product, you also gauge into the future. So most of these vaccines, you remember during COVID, vaccines are designed so that they can also capture several variants. And so these vaccines of monkeypox, about 2 that have been developed that have gone through clinical trial stages, and they are also used in they have been used in few animal and human population, has the capacity to cover several variants. So it is quite key that we also look at the local content development in terms of vaccine development. Most of diseases that emanate from Africa, vaccines should be developed in Africa to consider the strains in Africa. Mary, we have Lassa fever that was discovered in Nigeria, in a town called Lassa in Maiduguri. But the vaccines are not developed in Nigeria. The vaccines are developed in Europe and other parts of Asia. And so we need to build capacity, local content capacity in terms of vaccine development. You remember during COVID, we made noise about developing vaccines for COVID in Africa and all what have you. WHO gave licenses. Nothing happened post-COVID. So I think in the direction of looking at what is around us, it will also be good for us to see how we can develop vaccines that are locally patent to local strains beyond monkeypox, beyond COVID, vaccines of African origins. If I may also make submission, is that we must have a deliberate effort as a country or as a continent to see to how we go into vaccine development. If I am President Bola Ahmed Tinubu, I will set up a vaccine initiative to see how we can be able to have our in-house robust vaccine production.
Let's go on a short break, and we'll continue that discussion when we come. Please stay with us as we go on a short break. Meet us on the other side. Back. You're watching Health Matters on Channels Television, and we're talking about the resurgence of monkeypox and how that is causing jitters in the Western world. We're talking with Dr. Akiala Ishaku. You could call with questions. Call the number 0808 054 2233 for any questions you have, or send a message on X at CTV_Mary A, or send me email to moalale@channelstv.com. Doctor, the WHO has released some money, a huge sum. I think it's about $1 million, possibly, for countries to contain this Mpox resurgence. So I'm wondering, is any of this money supposed to go into what you were explaining before, vigilance and checking, all those things that show you how many variants you have, how close you are to getting a new variant, and what to do about it and all that? What is the money for?
So the money is released for containment of this virus, of these outbreaks in resource-constrained settings, and most especially in Africa. Now, it cut across genomic surveillance, it cut across active case search of cases that are positive, it cut across also case management. But it does not also preclude the issues of vaccine development. So basically resources are released for health system strengthening in terms of understanding the epidemiological outlook of the outbreak, and also how to contain the outbreak. So the money resources are also released as to go into preventive measures. So Mary, time has come. We must not wait for the next pandemic to happen for us to also contain. So we need to also be very, very reactive in terms of preventing a lot of outbreaks. Most of the times, we wait for an outbreak to happen, then we now move into a response phase, and then to see how we can contain it. But in the contemporary 21st century surveillance, you prevent it from happening. How do you prevent it from happening? Through active surveillance system, health system strengthening, and then through having a very robust health case management framework, and also into vaccine development. So you roll out immunization programs to contend with that. And so those are the key things that the resources are being released for. But I want to say that we must not wait for WHO to release money for us. As a country, we are in doubt. As a continent, we are in doubt. So what we just need to do is to look inward in terms of resource mobilization to contain most of this. This money that have been released will not continue forever. If you ask people within the public health space, they will tell you that
for a second?
A lot of...
Let's just invite Lucky to ask his question. Lucky is calling from Lafia. Hello, Lucky. What's your question?
Yeah, good afternoon.
Good afternoon.
Yeah, I want to really know what's happening to our existing research institute in the country. What are the successes recorded so far?
Okay, thank you so much, Lucky. Lucky is asking about what are the successes recorded so far in our own research institutes.
So there has been a lot of success in our research institute. It's just that we may ask for more, like Oliver tweets, for more funding and for more grants, for more funding for most of our research institutes. If we want to compete globally at international stage with other institutes of the world.
Lucky asked a very valid question. Before, a yellow fever vaccine.
Yes. Yes, Pawosu, in 1956, we got a license by WHO Afro to start the production of yellow fever vaccine. The public health laboratory in Yaba was responsible for that. In 1991, we lost it. And so, till then, the country lost capacity to actually produce human vaccines. MVRIVOI is doing greatly in terms of production of animal vaccine, but sometimes the technology is not the same. And so we lost that opportunity to countries like South Africa, to countries like Tunisia, to countries like Senegal in Dakar, to countries like Morocco, to countries like Egypt. So the hope of vaccine development in Nigeria does not lie within government research centers.
Let's take this call from Ben quickly.
Through public-private.
Can we take this call from Ben? Ben, what's your question?
Very much. This has been a wonderful program. My question is, we realize that based on his presentation and also that monkeypox, Mpox being it a zoonotic disease, and this is a situation that drives from animals to man. And so we have realized that hunting in almost part of Nigeria has been so much that some people even depend on it for some. What can we do to change the narrative of at least reducing the rate of hunting where this disease plays an important role from being animal to man? How can we, is there any way, what can we do at least to reduce the menace of hunting in Nigeria to at least?
Okay, I get your question, Ben. I'm going to turn it over to the doctor to answer. You did get that question, doctor?
Yes, I do. But in continuation from where I stopped before answering, going to what Ben has actually asked a valid question, is that if you look at our 4 refineries, 3 to 4 refineries that are government owned, they are not functioning until when Dangote came up with this refinery. Yes. So the way to go is that we need private individuals to come into the establishment of vaccine development biotech companies, which is quite key. Now, we cannot stop people from going to the bush to look for source of protein because of the level of poverty and the level of social insecurity. What we can do is to go into advocacy, just like the program that Mary anchors, like Health Matters. So we need to do a kind of robust advocacy, public health advocacy. We need to also see to how we can enforce certain national policies that cut across animal husbandry, that cut across issues of encroachment, desert encroachment, forest encroachment. We need to see to how we can educate our people on the need to not to have an interface with animal population in forests and other reserve areas. So it bounces back to advocacy. It bounces back to health education.
Thank you so much,
and that's the
Doctor.
way to go. For us to...
I really do have to stop you there, but thank you so very much for your answers. That has been a lot of education for us this morning. I want to thank Lucky and I want to thank Ben also, both from Lafia, for your questions. And I want to thank all the viewers. Have a wonderful day. I am Mary Alale Yusuf.